Welcome to UT Brainstorms. Thanks for being here. It's always nice. We work at this, and then you never really know until people start wandering in that it's going to be a good crowd. So thank you so much for being here. It's fun for us when you come. I hope it's fun for you. My name's Mike Mock. I'm a professor in the Department of Neuroscience, and most of you have been here before, I suspect, so you know the deal that we've been doing this for a while now, and it's the department's way of sharing our love for neuroscience and reaching out. And just the reminder that there's always a long question and answer period for every Brainstorms, because you may not appreciate it, but what we get out of it is we learn a lot from your questions. So it's really intended to be a discussion. We hope we answer your questions, and I can assure you that we're going to learn a lot from the questions that you ask, okay? Important things first, there are parking vouchers available. Just pick one up on the way out. They're good for the San Jacinto and the Speedway garage. There's a QR code here. You just scan it in the little gizmo on the way out. That's all you have to do, okay? Feel free to take one. Happy to pay for parking. So it's a pleasure tonight because even though our speaker, Dr. Jose Milan, isn't a member of the Department of Neuroscience, he's certainly a member of the UT Neuroscience family. Dr. Milan is one of the world's authorities in brain-machine interface. We're really lucky to have him here at UT, and we're delighted to have him here tonight speaking. And so we'll get him going in a second. He'll talk for a little bit, half hour, 35 minutes. He'll invite his panel up, and then we'll do what we usually do, which is you can scan that QR code and use the app or that website to type in questions. You can do that even while the presentation is going on. You can raise your hand. We'll go back and forth. That way, if you prefer one over the other, we get everybody involved, all right? So, I thought a lot about how to introduce Dr. Milan, but he's so distinguished, and his accomplishments are so many, and his awards so impressive that there just isn't time. Just be assured that we're lucky to have him here. I have to say, I was part of the search committee that helped attract him here, so I'm pretty proud of that. You'll see that this field is amazing, and what a perfect topic for UT Brainstorms. And so I should just get out of the way and let Dr. Milan go. So.
Thank you so much. Okay. So thank you so much, Mike. It is a pleasure to be here with you today and to share with you a little bit of this fantastic, incredible field of brain-machine interfaces or brain-computer interfaces. Let me start saying that I will be introducing technology grounded on neuroscience, of course, but the focus of today's presentation will be in showing you how when humans, brains, interact with technology, then something happens in the brain. The brain will change. We will be talking about plasticity, how the brain changes as people are using a brain-computer interface. And now, if the brain changes, then eventually we can use it to drive changes that will induce recovery in people who may have damage caused by different kind of neurological conditions. And I cannot be exhaustive, but I will be showing you examples. So let me start with the basic architecture of a brain-computer interface. So we will need to record brain signals in a wearable way, because we would like people to use their brain-computer interfaces anywhere where they are. Then we will need to analyze those signals, and here we will need to use a lot of knowledge that comes from neuroscience, where in the brain we will need to go and look for. We will need to use principles of engineering, signal processing. How can we analyze those signals, tiny signals that we are recording, in a way that we can see them better? This is called improving the signal-to-noise ratio of a signal, if you are a little bit technical. And finally, we will need to use machine learning principles, because at the end of the game, we want to understand, we want to decode when people want to deliver mental command A or mental command B in order to control different devices. And the loop is closed because, as anything that we do in our life, we are using the feedback that we are receiving. Are my commands, my mental commands, correctly decoded so that those devices are doing what I want them to do? Yes or no? Because this feedback will allow us, as subjects, to change the way we are generating our brain signals, and we don't know how do we do that, because we don't have sensors inside our brain, but we learn. People will learn to do so that they can deliver better and better commands to machines. So there is a lot of learning here, because we will have the machine learning, the artificial intelligence on our side, but we will also have the humans learning. And today I will be putting especially emphasis on this learning process, and then I will be also introducing some sketches of algorithms that will allow us to do better decoding with machine learning, artificial intelligence. How can we measure the electrical activity of the brain? Because this is the kind of signals that we will be exploiting because of the dynamics of these signals, meaning that these signals can change, and change actually very quickly. And this is what we need in order to be capable to control machines. We want to do it on the split of a second. So we can do electroencephalography, simply recording from outside, or we can implant electrodes in the brain. And we can use two essential techniques. One is indeed inserting electrodes that will be very close to the single neurons that are the basic of the electrical activity that we are generating in the brain, because it is the firing of these neurons that will generate the electrical fields. Or we can simply put electrodes on the surface of the brain in order to not read out individual neurons, but small populations of neurons. And recently there is a third technique that it is called intravascular, because it is possible to insert a device through the veins that are feeding our brain, so that from the inside of these veins we can record also the electrical activity. In today's talk, I will be focusing more on the non-invasive side, but you can see that, of course, there is a lot of advances also on the use of these implanted penetrating electrodes in order to infer what kind of commands, what kind of actions people want robots to do. In fact, the reason why I will be focusing more on the non-invasive side, the EEG side, is because since it doesn't require any surgery, then we can reach out to way more people than if you need to go through a surgery, isn't it? In fact, we have been working with a large amount of people over the years in my lab, more than 1,300 people, and more than 200 of them were people with severe disabilities. This doesn't mean that everybody were capable to achieve perfect control with a BCI. As everything in life, some could learn faster and better than others, but all of them were capable to achieve a certain degree of performance. So let me show you the first example. This is the case of people who suffer a high-level spinal cord injury, so high at the cervical level that they are completely paralyzed. They are called quadriplegic or tetraplegic. And now the question is, these people have not been using their body for years, many years in some cases. Could they learn to control a brain-computer interface so as to drive their own wheelchair? So this was an experiment done in cooperation with colleagues in Bochum, Germany. And we were working with 3 of these patients over several months. We know that during the training, the first patient, patient number 1, had a better performance, brain control performance than subject 3, and subject 3 was performing better than subject 2. All 3 were capable to drive their wheelchair, though. But we know that, as I was saying before, the degree of control may change over time. I will summarize the whole experiments that we did with them, saying that this was the last task that they had to do. This is the schematics of the rehabilitation ward where they come regularly in order to receive some therapies. And what they had to do is, starting from this position, bottom right, to drive the wheelchair along these waypoints, so that they had to go to the left of waypoint 1, right of waypoint 2, turn back, and so on and so forth, until they exit the room from the bottom right side. Now, what you are seeing over here in color, it is a representation of how often the wheelchair was, across all the trials that these 3 people were doing with the wheelchair, how often the wheelchair were passing by every single point in the room. So that if it is completely blue, means the wheelchair never went there. And the warmer the color is, the more often the wheelchair was passing by. In black, you see the optimal trajectory that we can generate, we can compute using robotics principles. Essentially, this optimal trajectory is saying keep a safety distance to object so that there is no risk of collision, and be as smooth as possible so that the speed is the highest as possible so that we finish the tour quickly. And now you can see that when you show this, how often the wheelchair passes by every point, there is the emergence of the average trajectory that people were generating that is very, very close to optimal. So they learn. But this was not the whole question that we were asking. We were asking also, what is changing in people's brain as they learn to control the wheelchair? And what I am showing you over here is not the actual electrical activity of the brain as they were delivering the commands to the wheelchair to generate this trajectory. What I am showing you here is how discriminant meaning how different is the activity in a given point of the brain, of the cortex, whenever the subject were delivering command A, command B, or command C. This is what we call discriminant, because this is what we want to see, that people were modulating their brain electrical activity differently whenever they wanted to deliver the different commands. Because that means that then the brain-computer interface could understand clearly the commands. And now you can see that in the case of subject 1, this discriminant value grew linearly over time to become something very strong and very stable. We have the same somehow for subject 3, but you can see that the process for subject 3 was totally different. Here, they were reinforcing the original ones. Here, at the very beginning, was a little bit chaotic and converged to something else. Whereas in the case of subject 2, nothing changed. Subject 2, in a given sense, didn't learn. But interestingly, subject 2 was the one who was the best at the very beginning. And his performance was okay, so that he didn't have the need to improve anything. And now you can see how important is this discriminant factor, because we can see that if we take every command that they were delivering over the different trials, and we ask, which is the relationship between the discriminancy at any time and the speed at which the brain-computer interface was decoding their intention, you see that the more they are discriminant, the faster were the responses of the brain-computer interface. And this is important to control robots, because you cannot miss your turn because you are still thinking out what the robot has to do. You need to do it here and now. Let me move to a second example. This is again a spinal cord injury patient, but at the lumbar side. So this patient is paraplegic. And the most important thing for him was, can I control eventually an exoskeleton, a walking exoskeleton, so that I can take steps? So this guy was learning how to deliver the left step, the right step command. Up, up. So he was trained at the very beginning while seated to control that avatar over there. You can see over here the avatar is saying, I would like to take the right step, right, left, and the subject was controlling. But at a certain point, he was telling us, hey, I am feeling something different. I have the impression that, so he is paraplegic. He was not having any sensation or very little sensation. He didn't have any kind of muscular activity or very little. I think that something is happening. I say, okay, let's do something. Let's put you to an intense BCI training inside now the exoskeleton. So the first thing that we need to do is to train the person who has been seated and not standing up for more. If I remember correctly, it was 12 years at that moment. So you cannot put people like that standing up. They will collapse. So they need to train in order to sustain the vertical position. So we trained him for 3 months, and then we were doing clinical evaluations before starting the training, after the end of this physical training to stand up, then we did the BCI training. We repeated the evaluations immediately after and 3 months after, okay? These evaluations consisted of some neuroimaging and clinical assessments to evaluate the sensory side, the motor side, the pain side, etc., etc. So, in a nutshell, you can see over here that his motor scores were very poor, didn't change much between the baseline before the physical training and immediately after, because one possibility was simply by training to be in a vertical position, he could have some benefits, he didn't. Whereas immediately after the BCI, he had, and didn't change afterwards. At the level of pain, his pain was reduced also immediately after and 3 months after the BCI training. And at the level of sensations, he recovered a substantial amount of sensation. He is still paraplegic. I am not talking about miracles. He cannot walk, but he has a better condition. And now at this point, we started to say, wait a minute, if long-term use of a brain-computer interface induces plasticity changes in the brain of people because they need to learn how to reorganize their brain electrical activity in order to command, to control the brain-computer interface, this opens up the possibility to use the brain-computer interface directly for rehabilitation, not just as an assistive device that eventually, like in the case of this paraplegic person, may have some benefit. Now, let's design interventions where we will be targeting plasticity for recovery. And this is what we did in a study where we involved 27 chronic stroke patients, chronic meaning at least 10 months after their stroke episode, meaning that during some period of evaluation, their condition, functional state didn't change, so that their normal therapy was not having any effect any longer. And then we recruited them. What did we do? We were using our brain-computer interface. We were, all of them, independently of their functional score, had a common condition. They were paralyzed for one of their hands. One of their hands they couldn't use. So we were targeting that hand. We were asking them attempt to do this kind of movement, to open your hand. You say, why to open and to close? Well, just for you to know, if you have a person who is in a chronic stage of a stroke, most probably they will have a spasticity. And this is the symptom that you can really recognize very easily. So if you ask them to close, their spasticity will increase. Actually, the therapy is let's reduce the spasticity so that afterwards they can start using their hands normally. And this is what we target. Opening, not to foster more spasticity. And now whenever the BCI was recognizing the coding, that indeed they were attempting to do so from the analysis of the perilesional area, meaning the area that it is healthy around the lesion that was encoding the movement of the hand, and this is why their hand couldn't move, then we were delivering electrical stimulation over the peripheral nerves, and this is called neuromuscular electrical stimulation or functional electrical stimulation, and these currents will excite the peripheral nerves, in this case the extensors, and will induce the contraction of the extensors muscles to open the hand. But in order to check that this was effectively working, we had also a sham group. What does it mean, sham? They were receiving the same instructions, they were wearing the same apparatus, but the stimulation was random. They were stimulated, they could open their hand, but there was no association between their mental state, actually their physiological state, and the moment they were receiving the stimulation. Very quickly, you can see over here Fugl-Meyer score, meaning this is an index of function. The higher, the better. This was similar for the two groups, quite severe. And then you can see that at the end of the intervention, only the BCI group improved, not the sham. And this improvement was clinically significant, meaning that these patients could do things that they couldn't do before. One of them was capable to bike again because he could use the brakes. Another one day when I entered into the clinic, he was like that all the time. And then that day he was, Professor, look at me. I can move my hand. I can move my arm. We cried very regularly doing these experiments. And and you can see that this improvement was preserved 9 months later. Whatever they recover remained. And what changed in the brain? Because we were hypothesizing that we were inducing plasticity. Well, very briefly, what we were estimating is how much information is flowing between different areas of the brain. In particular, inside the part of the brain that was damaged, the primary sensory motor cortex. And you can see that at the very beginning, there was almost no activity in none of the groups. And after the intervention, the amount of information that was reflowing inside the damaged hemisphere increased for the BCI group. And that this increase in, technically, this is called connectivity, how much information is flowing between 2 points, this is correlated with improvement. You may be very happy, but we were not. Because if you pay attention, there were a few red points over here, the BCI subjects, who didn't improve. So the question became, how can we, at this point, improve our BCI technology so as to increase the chances for everyone to benefit? And one problem that we have with brain-computer interfaces, no matter the kind of signal that you are using, invasive, non-invasive, through the vein, through electrodes implanted, is the fact that the brain signals are changing all the time. And the reason is very simple. The reason is due to the fact that the way our brain encodes function is very robust because it is distributed. Every neuron will be participating in the encoding of several functions. This is why, even if despite that neuron dies, and they will die sooner or later, you still preserve the function because there will be other neurons that are also encoding that same function. But this means that even if you are saying, no, but I only want to move this finger, Well, the population of neurons that will be encoding this stupid movement will be changing over time. Because at the very beginning, I will be very focused. And after a while, I say, well, do I need to keep it doing for longer? And then you start thinking on your own flies, and this is annoying, and blah, 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 blah. So more neurons will start interfering with that. Technically, what I am telling you is that if I collect the data to build by BCI, I can have a very good separation between the activity whenever I want to deliver the command red and the activity whenever I want to deliver the command blue. But tomorrow, when I try to use the BCI to deliver red or blue, the problem is that these signals, poof, will be shifted in a space, in the space that we are using to build our BCI. And now this line that were separating the two, the red from the blue originally, will not be a good line to separate the red and the blue of today. And yet there is a separation over here. So a little bit technical now, but not too much. What we can do, and we have developed, and we are improving, and we are not the only, is techniques to say, how can we make a transformation of this data here and now so that it fits the original data? How can I remap the data that I am collecting today so as to maximize the distribution of the data that I recorded when I was building my BCI? Long story short, we can do even so when I have a BCI already trained for someone who is an expert, who can control very well the BCI, and now I have a new person, a naive person, who has never used the BCI. We know that this person will need to train for some time. Well, if I assume that the two, the expert and the naive, will have some similarities because they will be modulating the same brain areas whenever they want to deliver the same commands, then I can apply the same principle. I can say, let's find a transformation so that the two come together and the new subject can benefit from the BCI that I already have for the expert. We tested that for people who were controlling a very simple task, simply to move the bar to the left or to the right to deliver left and right commands. And the same day, they were trained to control a video simulator of a car in a racing, okay? Also delivering left and right commands. Now you can see that over 5 days of training, first, they improved the performance almost linearly. Every day they were performing better and better and better. This is for the bar, and this is for the car because they were rising faster and faster and faster. But you can see, especially here, that this initial performance was already much better than anyone that we had before that was training from scratch the very first day. In total, there were 9 subjects. Almost everyone was improving day to day. More importantly, we were also asking how are these signals, the brain signals that we are collecting, changing over time. And we saw that this discriminancy, how they were separating better and better the two commands, were increasing over time in the two tasks. And importantly, in this framework, if this was the original mapping of the expert, people don't need to imitate the expert. Everyone was modulating their signals in a different way, in a personal way. And this is important because lately we are developing brain-computer interfaces that where we have an expert. This expert is a healthy subject, a student in my lab, and now we are testing these BCIs with ALS patients who have a neurodegenerative condition in their brain. And they can control the robot that they are using. You can see over here that they can modulate signals in the way that a healthy person should modulate. And we have experience with ALS people who were trained in the classical way, where they cannot sustain this kind of modulations due to their neurodegenerative condition. What else can we do? When I was telling you that signals are changing, I was telling you that one of the main reasons is that there will be different populations of neurons that will participate in the encoding of the mental command, and you cannot control which ones you will be recruiting. It will take a long time for you to teach your brain to be very consistent. What we can do is to use principles of neural engineering, in particular neuromodulation, where we can inject currents into our central nervous system in order to constrain the dynamics of my signals. In particular, I can inhibit, so deactivate, just to say it simply, parts of our brain, so that the only part that will be modulated is that part that the person wants to activate. So we were using a particular technique where, rather than delivering currents directly on the brain, these currents were delivered on the spine. And as a result, the whole brain was in an inhibited state. And now, whenever the patient wants to, say, deliver the command left hand, only a minimal part of their right cortex, motor cortex, will be activated. This was the hypothesis. And you can see over here that indeed, if you take this group that is the group that was using the neuromodulation, as compared to another group that didn't receive neuromodulation, you can see that both were learning, but the neuromodulation, the one where we were constraining the dynamics, was learning much faster and better. So in these experiments, everybody was capable to learn whenever they were using the neuromodulation, and as it happens every time that we do an experiment, there were a certain number of subjects in the control group who was not receiving neuromodulation who couldn't learn. 4 of them. Let me come back in a moment to those 4 subjects. So here, this is the hypothesis that we were constraining the dynamics. And here I am showing you how focal was the modulation of the signals that these people were capable to generate, to induce, in order to deliver the different commands. And you can see that this focality was stronger and stronger and stronger over time. Something that didn't happen in the others because the process is kind of random. Now, 6 months after this first experiment, we call back those people who were not capable to control in 5 days their BCI when not receiving the neuromodulation. We call them the slow learners. They will need more time than usual. And now we apply to them the neuromodulation. Guess what? They learn much faster, as faster as the other. And they develop also this focality. So this seems to be a principle that now allows everyone to learn. We are testing this approach with patients, and they are recovering. And you can see again that this focality is correlated with performance. I want to change. Do I have 5 minutes, Mike? I want to change. Not topic, but the kind of signals that we can use to control a BCI. Because a BCI is not constrained to motor commands. We can decode, in principle, whatever mental state the subject is going through, as far as that mental state is useful for our interactions with the world. Okay? So we call them cognitive states. And now I would like you to play a little game with me. So now I need my 2 hands. I want you to do this. I will be showing you over here pictures, and they will go very fast. And I want you to clap whenever you see an animal with 2 legs. 2 legs, only. And if you can't, you tap whenever there is no animal with 2 legs. Clap or tap. Okay, are you ready to go? So hands ready, and let's go. Why this doesn't work? Up. Here we go. Clap 2. Tap, no, 2. My students are better, eh? Even undergrads. Okay. Stop over there, stop over there. Fail game. But I hope that you have experienced the I am about to clap when I shouldn't, or to tap when I shouldn't. And you are aware that you are about to make a mistake. The issue is that you cannot stop doing the mistake, and this is the topic for another Brainstorms. But you can also distinguish very clearly in your mind, you are aware of situations where you observe some wrong behaviors. For example, you want to deliver the command A to your wheelchair, the BCI makes a mistake, and you see that the BCI starts moving in a different way. And as soon as you start perceiving that the wheelchair is moving in a different way, you say, stupid, this is wrong. And faster that you can say all that and express any no, there is a signal in your brain that will be elicited in this area over here on the walls of our hemisphere, cortex, that is called the anterior cingulate cortex, that we can measure from electrodes along the medial line, and these signals are generating a modulation whenever you perceive a mistake. You say, and this is useful for what? Well, imagine that now you can decode that signal before the wheelchair makes the wrong movement. You could stop making mistakes. You will be saving a lot of time. You can also use those signals to teach robots how to generate trajectories that, for example, will allow you to manipulate objects from one place of the table to another place while avoiding crashing with other objects. The idea is that as the robot is moving, you realize that, oh my goodness, this is wrong. I don't like that kind of trajectory because it is passing by too close to another object, or it is passing by too far from another object. This is taking too long. I want to go faster. Now, as the robot is moving, we can decode those error-related potentials, as we call it, and we will use those error-related potentials to teach the robot how to do those trajectories. And this is important for people who have disabilities because they cannot control the robot, precisely because they have disabilities. But they would like the robot to perform those tasks for them. And how can they do so with this error signal? The interesting thing, I will skip all those experiments because this is not the most interesting part. The most interesting part for me is that as a result, of course, everybody has the concept of what is a good trajectory. Yeah, but as far as we start putting numbers to how good it is a trajectory, most probably, as in these experiments, everybody will have a different preferred trajectory because everyone will have different criteria. I am a stress guy, I want to go fast, no matter the risk that I am taking. Some others will say, no. Risk is not with me, take it easy, take your time, okay? And in fact, everybody was generating a different trajectory. We can now personalize the way robots will be executing tasks in a way that reflects our choices. But this talk was about plasticity and eventually recovery or improvements. How can we exploit these kind of signals for those purposes? Imagine that now you are performing a very stupid task. You are controlling a joystick in order to bring the cursor to a target. And the instructions is generate the straight line. And of course, you cannot generate always a straight line, but you will go as straight as you can. And now, from time to time, and you don't know when, we will be generating rotations to the trajectories that you are performing. You keep moving, but the cursor will rotate a little bit. Depending on the degree of the rotation, if they are 9 or 12 degrees, this is easy. You will realize immediately, and then you will correct. But when the rotations become very small, especially 3 degrees, most of the time you don't even realize. And you think that this not very straight line is because you are not good. Sometimes you do it better than other times. You presume that it is your fault. Well, we were training people, and this is called perceptual learning, to detect those errors. And we were training these people using classical behavioral training, because at the end of every trajectory, we were asking them, did you see a rotation? And they were saying, yes, no. And then you say, you were wrong. There was a rotation when you said that there was none, or you were wrong because you said that there was a rotation and there was no rotation. And these people could learn, obviously, practice makes us better, except for the small rotations. For the small rotations, no way. After 5 days, they couldn't learn. And then we have another group where we were decoding the error-related potentials because we want to be sure that they are perceiving those mistakes, and we were delivering them feedback not on their answer, did you see? We were not even asking. We were delivering feedback on whether or not they were generating the error-related potential when there was a rotation. There was a rotation and they were generating the error-related potential? Correct. There was no rotation, there was no error-related potential? Correct. There was a rotation and they were not generating the error-related potential? Wrong. There was an error-related potential with no rotation? Wrong as well. First, you can see how the amplitude, in particular of this component, the P component of the error-related potential, was matching, was encoding the amplitude of the mistakes, of the rotations, okay? And this is important because this is the conscious component of this signal that we're expressing I see, I am aware of. And now you can see that the group that was doing in red the classical training couldn't learn, whereas the group that was receiving BCI feedback improved. And they were performing at the end better than random. Still, it is very difficult. They were not perfect, but they improved. And finally, you can see like the amplitude of this P component, that is the conscious component, increased significantly for people who were capable to learn. I hope that you have learned a little bit about the field of brain-computer interfaces. I hope that you can see that brain-computer interfaces can work with different kinds of signals, but the common element that I wanted to convey today is that the use of a BCI induces plasticity, and that we can use that plasticity for good. Thank you so much. Samantha is a professor in the Department of Biomedical Engineering. She's doing the invasive BCIs. So questions on invasive BCIs to Samantha, together with John. John is a professor in neurosurgery. He's a neurosurgeon, and he implants these devices on people. And finally, we have Jared from the Department of Neuroscience, and he is interested in brain-computer interfaces, mainly non-invasive, for inducing this plasticity, for inducing perceptual and learning components. And you can interrogate them about the kind of things that they are doing now that they are with us.
All right, so you want to raise your hands if you want to ask a question that way. It's good to get my attention. It's better to get the attention of the students who have the microphones in their hands. So does somebody want to? She's close. Let's start.
Good evening. Thank you so much for that talk. I was curious about the BCIs that are implanted in the vasculature and how that works and how you get like region specificity. Do you go in through the carotid? Yeah, I think that's my question. Thank you so much.
You want to answer, John?
Yeah, so there's a couple of companies that are developing those types of BCI, and the reason they're doing that is because it's actually easier to access than, say, doing a craniotomy, opening up the skull, opening up the coverings of the brain to get something very close to the brain. So the way you access these blood vessels is the same way you might access, say, the heart, or the way you do, say, an angiogram where you're putting contrast in the blood vessels and taking x-rays or CT scans to see. So you basically drive a catheter from a peripheral vein in the wrist or the groin, and you drive that up into the blood vessels of the brain, and then you can implant a device, a little fine mesh wire type of device with a tail down to some other implantable device. But the electrodes themselves can be implanted in vessels that are right next to the brain. Now, the reason that's being done is because it's easily accessible to do that, relatively speaking, but it's still being explored what you can actually do with that, with the limitations of where you could put that, and what the potential long-term issues with that are. You know, it does bring up one issue with brain-computer interfaces, which is when you put something in, you have to have an exit strategy. And when you put something like that in a blood vessel, what happens is it's probably going to be endothelialized, incorporated that blood vessels, and it's probably something that can't be fully ever retrieved. And what are the long-term consequences of that? So what are the advantages? What are the disadvantages? That's being worked out. Did I address your question?
I am curious if you have like region specificity. Are you saying something else is implanted and then the device is able to connect to that?
Yeah, so I don't personally put these in, but I'm familiar with some of the companies that are developing this. And so, yes, what you're doing is you're putting electrodes in proximity to an area of the brain that you want to sense a signal from, but you still have to have some way of getting that signal. And so there may be a tail of a wire that goes off, is dangling down that long blood vessel, and then is externalized to some other device that could be implanted in the chest, for instance, where you could have an actual pacemaker that you could interrogate, and that would be a way that you could record those signals, and you could also potentially do some sort of stimulation through those electrodes as well. So this is analogous to what we already do, deep brain stimulators, which we've been doing for decades, where we will put an electrode through the brain into a specific location where we want to sense and or stimulate, and that electrode comes out to a tail implanted under the skin, goes into the scalp, down to the chest, or some other location where you have an implantable device that you can stimulate, or you can record, or you can create closed loop where you can stimulate based on what you're recording. So the concept is the same. It's just a different sort of different sort of device and different sort of access.
Thank you.
So there were several questions that I'm going to paraphrase to what's the future of this? So people were wondering, what's this going to look like? And use your imagination. What's this going to look like in 20 or 30 years?
The question was related to BCI in general or to the BCI in general?
Yeah, I think we could go wild. So the brain-computer interface fields, I think, really blossomed out of developing therapies related to movement disorders and motor disorders. And we've seen that really evolve fairly recently and broaden out to a lot of different applications, with things just in the past year or two really exploding for speech and using brain-computer interfaces for speech. So I would expect that we're going to see continued broadening out of BCIs for other types of sensory systems, and expanding the treatment options we have related to other sensory systems. Also being generally used more broadly for rehabilitation, not just for motor rehabilitation, but for psychiatric disorders and other types of conditions where learning to volitionally control neural activity could have benefits. We've talked a lot about controlling signals that are the electrical signals in the brain, but the brain works through communication of electrical signals and chemical signals. And so I think there's a lot of potential to learn to volitionally control activity of one modality to influence another. So I think it's wide open in what we could see. And I'm also optimistic that the accessibility of these sort of technologies will increase as we learn more and more about how we can leverage ways in which we interface with the brain and learn more about how the brain works.
Hello. I was very interested when you mentioned, I think, the deep brain stimulators and potentially controlling neural activity. I was wondering if there's any research on with patients who have brain aneurysms and after that may tend to lose nerve function in certain areas, for example, like drooping eyelids or ptosis. Is there any research about potentially, healing them faster or helping them regain nerve function?
What I can comment on is a little more broadly the use of brain stimulation or brain-computer interfaces in order to try to improve function generally. So sometimes that's after some sort of stroke. You mentioned aneurysm particularly, but that could just be some sort of stroke. So the idea, there's many devices for improving function that is lost. So there can be loss due to neurodegeneration. We think of, say, Parkinson's disease is sort of our classic example. You're losing a group of neurons slowly over time. That's causing a dysfunction. That creates network problems in the brain where some networks are underactivated, some networks are overly activated. That creates dysfunction when you're trying to interact with the world. And so what we're trying to do with the stimulator is we've located a particular node in a circuit that is overly active or has a pathological oscillation in it, and we're going to put an electrode in it and then enforce a different type of oscillation that allows the circuit to function more normally and therefore the patient to function more normally. When it comes to more like recovering from a neurological injury, say a stroke, something different may be happening where you've lost a variable swath of brain cells in a wide area, and that's resulted in, say, weakness or numbness or inability to speak and so forth. So there's a degree to which the remaining brain can't compensate for that. We were talking about that a little bit. So, the brain can often solve problems many different ways. There's sort of the way the brain was intended to solve a particular problem, but when forced to solve that problem a different way, it can do it. It might just be less efficient. For instance, if you lose a toe, right, you can still learn to walk. You may not win marathons, but you can actually walk pretty well. You keep losing toes and you may not be able to walk so well. I mean, it's a gross metaphor, but I mean, the point is you can take out circuits in the brain and the brain can still solve problems. It may do it less efficiently. However, using brain-computer interfaces and neuromodulation, we may be able to help that efficiency and help along circuits that can help with the recovery. So for instance, there's a device, a vagus nerve stimulator, that can be used to enhance occupational therapy so that when you're recovering from a stroke and trying to regain hand function, once you've achieved all that you can with just standard of care occupational therapy, you can have this device implanted, and then you do occupational therapy again, and as you're doing those commands, the stimulator gives a little salient signal to the brain, and that helps push along on those circuits on a road to recovery. Similar devices into clinical trials in the cerebellum. We're looking for ways to actually regrow some pathways with cellular therapies and gene therapies and so forth. So yes, I think this is broadly, there's a lot of approaches that are trying to do the sorts of things that you're talking about.
And maybe this is a good moment to add that none of the interventions that you can think of by themselves will solve these complex conditions. We need to advance each of them, but the final goal is how to combine them in a way that will maximize that person, that may require a different combination than that other person.
So my question is BCI and epilepsy. Have you looked at it? Because Dr. John talks about seizure, VNS, and non-invasive way to prevent electrical stimulation. Is any? Thank you.
Anyone wants to answer?
Yeah, I am an epilepsy surgeon and I use BCIs. Does anyone know when the term BCI was coined? What year? It's the same year I was born, 1973. So, the concepts and the devices have been around for a long time. So epilepsy specifically, if we're just talking about that, there are BCI devices, types of neurostimulators. some that are open loop, some that are closed loop. What we mean by that is, again, the idea that you're just going to be stimulating a particular location and that's going to have an effect on a circuit over time that can be therapeutic and reduce this frequency of seizures. There are closed loop devices that literally sit in this epilepsy onset zone, and when they record the onset of a seizure, it stimulates. You can think of it like a defibrillator for your brain. And it works to some degree like that, and some of it, again, is just what the effect that it's having on a circuit over time. But we need better ways of treating epilepsy with neuromodulation. Those are invasive versions. There are non-invasive versions that we are working on. Temporal interference, direct cortical stimulation, focused ultrasound. There's lots of ways of interacting the brain less invasively. The question is how safe, how effective, and how do we do it better?
So there were a couple of questions. You talked a lot about the BCI discriminating A versus B, and there were a couple of questions that were in its current state. What's the resolution? How many signals can be discriminated by a system like this?
It depends on the domain. I think the most effective current models that we're using for discriminating, say, perceptual discrimination of say, oriented lines or very simple stimuli are limited to still a few number of classes. So as Jose was showing us, this process of BCI training is very noisy. It's hard to learn to control these signals, and the more complex a problem you ask the brain to solve, the trickier it is to learn that task. But developments are being made all the time in this realm, and in the area of brain decoding, both invasively and non-invasively, there's lots of work being done that is exploding the space with which we can decode. It's not just categories of stimuli, but it's individual stimuli exemplars or individual thoughts that we might have that have very complex shapes and representations in our brain, and we're learning how to carve up that neural representation space of how our brain represents very fine-grained information, so that we can, that will then trickle into the type of work that we're describing here of closed-loop stimulation, where we can track these finer-grained representations. So just want to make another point about the applications of BCI. We've been focusing a lot on recovery and brain plasticity and targeting patients with neurodegenerative diseases and things like this. I'd say that BCI can be much more widespread than just patient recovery. I think that we are going to be seeing a lot more BCI in our lives, just like we've been invaded by AI over the past couple of years. I think BCI is going to be a very mainstream thing that is going to be augmenting our existence on a day-to-day basis. Think about new cars tend to have eye tracking systems right above the steering wheel that will tell you when it detects that you're not looking forward to paying attention to the road, right? That's just making a pretty simple inference about whether you're looking straight or left or right. Well, we might get to the point where in the cars we put in non-invasive recording devices that are tracking just not where we're looking, but what we're thinking about, and can give us indicators. And I know I see a thumbs down there. There are real concerns that we have to address with that. But we could dramatically improve safety if we can help people, not just in a driving setting, but in other environments. And if we can augment people and say, hey, you're veering off the wrong track inside your own mental space here, maybe there's a way that can be put to good use as well.
Question kind of changed. Do you think BCI can be transferred to augmenting, like someone with Alzheimer's, when they lose their sense of smell, with their fashion or with their clothes? Can BCI be intertwined in clothing to help people who have cognitive disabilities? And my real question was, could you follow up on the paraplegic study with the exoskeleton study? Why did you use the feedback avatar using the mirror feedback? What was the significance of that?
Well, we were using that because we started with the avatar before putting this person inside the exoskeleton. And we wanted to continue with the same, with the idea of introducing afterwards the movements, actual movements. But we couldn't reach that stage for different reasons. May I add, well, you can answer the cognitive side.
I just want to make sure I heard it right. Did you ask about Alzheimer's, but also about BCI and wearables? Yeah. Okay. So there's definite interest in brain-computer interfaces for Alzheimer's and other dementias. I think in particular in the deep brain stimulation space, people are interested in this. But there's also things like memory prostheses that people have been investigating. So that's also work in progress. Regarding clothing, so there is a category of brain-computer interfaces called wearables, which is more along the lines of what Jose was talking about, of non-invasive devices that you would wear on yourself. So those exist in a bunch of different modalities, from a cap you might put on your head to something like a sticky tattoo or temporary tattoo you might wear on your body. In terms of clothing, I think the only thing I've seen is from David Eagleman. He had a vest that he was working on for a while that had different sensors integrated in it. So the idea was that it would also give you like feedback about something and not really stimulation, but like vibration in different areas was a cue indicating something that was happening. It was unrelated to memory and dementias, but that was a wearable that was clothing based that I've seen.
Just to mention that there is a lot of work, and we are developing earplugs to record EEG. And we are decoding these error-related potentials from the earplugs.
Yeah, so I just want to comment on the Alzheimer's and then also on the EEG. So, we're talking, at the beginning of Jose's talk, he was talking about sort of this different scales, EEG, intracranial recording, you can even record individual what we call units, where you're actually recording individual brain cells. Different scales of data that you can collect, or what the brain is doing, can give you different information. So you can imagine EEG is like hanging a microphone over the city and saying it's rush hour, or basic things like that. But that's very useful information, but it's only so detailed for encoding, well, what am I thinking right now? It doesn't tell you that. It tells you, are you awake? Are you asleep? Are you having a seizure? But if you put electrodes maybe more broadly actually inside the head over a certain area, say the motor cortex, then you could get much more fine-grained detail about decoding intention to move and actions and so forth. If you actually put electrodes deeper and deeper circuits, you get a different type of information. It's different scales. So it depends a lot on what the problem is you're trying to solve. And then that leads to things like Alzheimer's disease and Parkinson's disease, for instance. The disease itself has different inherent natures to it. So Parkinson's, in some ways, is simpler to us to try to help ameliorate, not cure yet, but ameliorate, because it's a relatively discrete group of neurons that's being lost, causing this widespread change. And by focusing on some very specific locations in the brain, you can do a lot to help it. Alzheimer's seems to be a much broader problem. It's not just a simple loss of one set of neurons that's causing these oscillatory pathologies throughout the brain. It seems to be much more widespread, so it's a much more challenging problem to solve. That said, there has been, until recently, an ongoing clinical trial of a type of DBS target for treating Alzheimer's, but basically the other thing that happens is we depend on companies, and companies have bottom lines, and sometimes they start to look at those bottom lines and they'll pull the plug. And so even when something looks promising, or a subset of the patients look promising, and we're making scientific advances, we're relying on companies or sponsors to do these things, and they'll say, yeah, this is not going to be profitable, we're losing billions of dollars, we're going to stop now. So, a big issue in BCI is who we depend on to help advance these things and whose agendas we're advancing. And so that limits sometimes our ability to make progress. And so these things can be slower sometimes than we'd like.
Yes. My question has to do with mental health. Years ago, we attended a conference that used transcranial magnetic stimulation for severe depressives. Can you bring us up to date on how that might fit in with what you're doing today?
I don't know, Samantha, do you have a comment? But so we do neuromodulation for psychiatric indications. So the history of neurosurgery for psychiatry has a bit of a sordid history. We think of psychosurgery, but it's actually been, a lot of it's overblown. At the time that psychosurgery started, we didn't really have very good options for treating people who were schizophrenic or psychotically depressed. These people were institutionalized. They had no lives. Until we developed certain class of medications, antidepressives, antipsychotics, we didn't have really good ways of managing some of these people who are injurious to themselves, injurious to others, and so forth. And so there were things done with brain surgery, and it started with basic concepts of what parts of the brain do what, and if you intervene on those parts of the brain, does it help something? And this history of this started, 100 years ago with lesions, right? So we found things like lobotomy. That's not cutting out, lobotomy is removing, but lobectomy is maybe cutting something. And that has been whittled down to finding a very specific pathway in the brain and cutting a tract. So in the same way I was talking about a DBS can maybe help reduce the overactivity of a circuit, well, you could also put a tiny little hole or ablation right there and you can reduce the activity. And often it has the same effect. It's just the stimulation allows us to turn it up, turn it down, regulate it, whereas the ablation seems icky because we're putting a hole in your brain and we can't really reverse it. So we try to go towards technology in doing these things. And then you bring up TDCS or transcranial stimulation. Sometimes what we're targeting is very close to the surface, and we can get to it very easily, non-invasively, with things like ultrasound or electrical stimulation. Sometimes the target we need to reach is much deeper, and so we actually have to put something invasively or use a different modality. So increasingly, we have the ability, obviously we can put an electrode very deep in the brain and use that to do something like a lesion, or we could use transcranial magnetic stimulation to target a particular spot in the left dorsolateral prefrontal cortex that happens to be where if you stimulate that repeatedly, some patients with depression will get a lot better. Sometimes it's more complicated than that. There's multiple different circuits and targets for depression. We're learning about circuits that we can target for schizophrenia. The substantia nigra is a DBS target for schizophrenia. There's deep brain targets for depression. There's superficial targets for depression. Multiple different types of energy that we're using, and we're figuring it out. We're trying to figure out what works best in what circumstance for what patient. And when that doesn't work, then what do you do? And we try to go from the least invasive. We'll try taking this pill. Let's talk about it. Let's do some psychotherapy. We go from the least aggressive to, okay, now we're going to do transcranial magnetic stimulation. Okay, now we're going to do a ketamine therapy. Okay, now we're going to do ECT. We're going to literally give you an electroconvulsive seizure and try to reset your brain and do it multiple times. And that seems to help people with depression until they're losing their memory. And then when people are failing all of that, we say, well, maybe we need an implant. Vagus nerve stimulator, there's an ongoing clinical trial of that. DBS, there's an ongoing clinical trial of that. So there's a lot going on in this space. It sounds scary, but we're making a lot of progress. Deep brain stimulation for OCD is a whole other topic as well. So yes, there's non-invasive, there's invasive, multimodal.
How do you think that neurosensory machines like BCIs can help benefit those in neurodivergent communities?
So, do you want?
Maybe Jared.
So by neurodivergent, do you mean like say autistic, for instance?
Yeah, like those on the spectrum.
Yes. So I'm not a know-it-all, I promise. So I study the temporal lobe in part because I study epilepsy, and there's a lot of temporal lobe epilepsy. But it so happens that the temporal lobe does a lot in visual processing, and one of the problems in people with autism is social-emotional interpretation of faces. So in part, sometimes to treat a disorder, we need to better understand how the brain works generally, and then we can help sort out how is it different in one type of patient population versus another. So we look at something like autism, where people have difficulty with social emotional processing, and so the better we understand, say, the amygdala and the fusiform gyrus and how our face is being processed and how do you interpret social emotional cues, like, if you tend not to look at people's eyes, you tend not to, interpret their faces correctly, or you may take cues the wrong way. So we're trying to figure that out. We're trying to do that by recording from the brain and doing tasks like games that help us understand how the brain processes these things. For example, I mentioned epilepsy. I do something like a brain-computer interface all the time, and that's with somebody with epilepsy. We need to figure out where their seizures are coming from. You may think of scalp EEG is useful for that, but in the same way that only tells us about traffic in the city, it might not tell us the key intersection where the seizures are coming from. You got to put electrodes inside the brain. So we'll have epilepsy patients where we put 300 or so contacts inside their brain temporarily. They come to the hospital, we wait for them to have seizures, then we figure out where those seizures are coming from. While they are there, they can do neuroscience experiments. They can volunteer for it. They've got nothing else to do sometimes. And so they'll play games. And so a very good example of this is we will show people faces. Say if I take a person and have images of their face from very fearful to very happy and morph that across the spectrum, and you do a very simple task. Is this face happy or fearful? Obviously, the ones that are very fearful, they'll say, oh, that's very fearful. The ones that are very happy, no trouble. It's the ones in the middle that are ambiguous where you'll actually start to separate out people based on various psychiatric conditions they might be dealing with. Somebody with post-traumatic stress disorder will see neutral faces as scarier. Somebody with depression will see neutral faces as sadder, and so forth. And so the same thing, by trying to figure these things out and what are the circuits that are involved with this, what's going on, and then how can we intervene, then that may, we hope, help us better provide some treatments eventually for people on the spectrum. Long answer, but that's my knowledge of it.
We have time for one more. If you can do a brief question, and we'll make them give a brief answer, and then we'll be in good shape.
Thank you. What about cerebral palsy? Can BCI help with children or adults who may never have had typical movement?
There are attempts, not always easy, because these people have abnormal movements that are interfering with their brain signals. So the question that the community is asking is this the reflection of the movement, or it is the cause of the movements? Because they are moving all the time. Do you want to expand that?
Yeah, I mean, I'll just, so cerebral palsy is generally caused from a perinatal injury, either, just prior to birth or after birth, where most often it's due to a hemorrhage in a deep structure of the brain called the basal ganglia. And the basal ganglia is important for regulating motor circuits. So since this often happens on one side, what will happen is you'll have somebody with a spastic hemiplegia on one side where they tend to be weaker and have tightness of the muscles that they can't control. It can be more profound, obviously. There's a lot of variations in it. There's a number of neurosurgical things that we do for it that are not BCI, and then there's the future, which basically heard about tonight, where if somebody can interact with a BCI and do rehabilitation, they can potentially improve their function. It's not necessarily here yet. What are we doing for autism? Well, for people who have spastic hemiplegia, where their muscles are too tight, you can give them oral baclofen. And then if that's not enough, you can actually put in a baclofen pump and infuse baclofen into the spinal canal to help relax that overly active nervous system that's making those muscles too tight. There's also a way that you could do something called a selective dorsal rhizotomy, where you actually find the nerves that are overly active and you cut a few branches of them to weaken those muscles just slightly enough so that there's less spasticity. So those are neurosurgical techniques that we do now to treat people with spastic hemiplegia. Depending on the type of dysfunction in the brain, sometimes DBS may be helpful as well. So there are a variety of things that can be potentially available, and then of course we're hoping that BCI will help us as well, but that's still on the horizon.
Okay, that's our time. Please join me in thanking Dr. Milan and the panelists. So you can go to utbrainstorms.com. We've scheduled the February one. It's in conjunction with the Science Week here on campus. And I'll be doing it. And the topic will be how social media and devices affect our brains. And so hoping that a lot of students show up. So you can see the date and the location on utbrainstorms.com. Hope to see you there. Good night.